Good afternoon, everyone, and welcome to NPH, when shunt no longer works. My name is Saba Jemfi, and I'm your facilitator today. Before we get started, I would like to take a moment to thank our sponsors for making this event possible. There will be ample time for Q&A after this session. To ask questions, please fill out the note card on your seat. Our greeter will come by and pick them up for you. In this session, participants will learn what happens if NPH symptoms return, including diagnostic, evaluation, and management options. I would like to introduce to you today Dr. Mark Hamilton, member of the HA Medical Advisory Board, member of the HA Board of Directors. He is from the University of Calgary, Alberta, Canada. Please welcome Dr. Hamilton.
Thank you very much. Can everybody hear me? That's good. So we're going to talk today about what happens when the shunt doesn't work. So I'll go through, just to give some background, I'm a neurosurgeon. I actually was a pediatric neurosurgeon for most of my life and did a transition to adult hydrocephalus care. I started off by looking after patients who I dealt with when they were children who were becoming adults, and then started getting into looking after adults who were having their first time diagnosis of hydrocephalus. So NPH is, I'm going to assume that there's enough background about this, but we can certainly answer questions related to that and how to sort out NPH if they come up. We're just going to talk mainly about that process where the decision to treat has been made, and treatment has been done, and then the question is there a problem with the shunt? Since the shunt is the most common thing that's used for treatment of hydrocephalus in patients with NPH. So I think it helps to understand a bit of what are the shunts, what types of shunts are available. And there are three common ones that are seen in North America and the world. Ventricular peritoneal shunts, or VP shunts, ventricular atrial shunts, VA shunts, and lumboperitoneal, or LP shunts. And a lot of what type of shunt is offered for NPH depends on where you are. In Japan, lumboperitoneal shunts have become much more common, more popular. VA shunts are not used as often. VP shunts are probably the most common type of shunt used in North America and Europe. I think that a surgeon really needs to become comfortable with one. Each of these has individual issues and nuances, but there's no evidence that any one is better necessarily than the other. They can all treat hydrocephalus. They can all treat the symptoms of normal pressure hydrocephalus. So just to give everybody some background about shunts, since we're going to be talking about the things that can go potentially wrong with them. A shunt is simplistically something that moves fluid from the brain, from the ventricles, down to another place, the belly, the peritoneal cavity. And the peritoneal cavity has the ability to absorb fluid. So it recycles the fluid. The spinal fluid, CSF, is made in the brain, from the choroid plexus, from the brain, circulates around, and eventually goes back into the bloodstream. So it comes from the bloodstream and from the brain, then goes back into the bloodstream. And this is a way of taking fluid off. While this is simplistically what a shunt does, I don't think we fully understand in INPH why it works. We know that if you do it, it works. What we're stuck with is trying to figure out why removing a little bit of fluid can make such a big difference in brain function. And it probably has something to do with the effects on brain pulsatility, on the other things that are going along with the diagnosis of INPH at the age that many of these patients will present with their problem. A valve has three basic parts. A ventricular catheter, a valve, or a VP shunt rather, has three parts: a ventricular catheter, a valve, and a peritoneal catheter. So a catheter can be thought of as a thin hollow tube, and for those of you that remember the Bic pens, when you took the cartridge out, it's about that diameter, more flexible and soft. The valve is the most complex part of the shunt system, and there are now these new programmable valves, which we'll talk about. And peritoneal catheter is the same type of catheter as a particular catheter, just longer. And all of these are placed underneath the skin for the shunt to run. And one of the encouraging things about IMPH is that if you make the right diagnosis and you've selected the right person, we know from those tests that we do that the symptoms have demonstrated they can improve. I'll come back and talk about that in just a second. And if those symptoms improve, then that can be mimicked with the shunt. And all symptoms have the possibility of improvement. So what do we do for testing NPH? If somebody has hydrocephalus and symptoms of gait difficulty, balance problems, cognitive problems, memory problems, and bladder urgency, frequency, and incontinence, is we often will do what's referred to as either the TAP test or the lumbar drain, where we remove spinal fluid briefly for the TAP test, or the lumbar puncture, or a lot of spinal fluid on a regular basis, hourly, remove spinal fluid over a 3-day period to see what the effect is. Ultimately, how good somebody's going to get after a shunt depends on how bad things were beforehand. And sometimes that bad is just an effect that is reversible, and sometimes it's not reversible because there's been brain injury that's occurred. So ideally, we'd like to get people, before they become too severe with the effects of the hydrocephalus, in for treatment, because that's a better time for them. And we've seen that long-term follow-up demonstrates sustained improvement. So we've got experience now that's growing with people who have been followed for 10 years and longer. Other things start to intersect with your life when you're 85. Other problems can occur, heart disease, lung disease, things that can affect some of the symptoms that are related to hydrocephalus, but affecting them in a different way. So some of those can happen, but on the whole, the shunt treatment of the hydrocephalus itself is a sustainable thing for most people. And some of these other things that can occur, as I mentioned a few, but other causes of dementia, so normal pressure hydrocephalus, or rather idiopathic normal pressure hydrocephalus, I think increases with age, so that the prevalence is probably much higher in somebody over 80 than in somebody over 65. So Alzheimer's can intersect, so you can have both Alzheimer's and hydrocephalus. High blood pressure, coronary artery disease, stroke can all affect this and are probably partially related to how idiopathic normal pressure hydrocephalus symptoms are produced. It's part of what goes on in the brain to cause this problem. Obesity is a common thing that we deal with in patients, and sleep apnea. And it may be that these two are partially related to producing some of the effects with hydrocephalus, but they certainly also increase the challenges making a shunt work in hydrocephalus. Diabetes, another thing, because it affects blood vessels, it increases the risk of infection for patients with an operation. And then finally, anticoagulants and antiplatelet drugs. So antiplatelet drugs would be aspirin, Plavix, other things that are used for stroke, for heart disease. Lots of people are on them. If people have had stents put into their heart after angioplasty, they often are on these drugs. They're blood thinner drugs, and you can't do shunt procedures or lumbar drains when people are on these medications. Anticoagulants are used for heart rhythm problems such as atrial fibrillation, and there's a lot of that. All you have to do is watch the news and watch a few of the commercials, and you'll see all kinds of different anticoagulants, the so-called newer anticoagulants and the warfarin anticoagulant. So lots of these drugs are in use, and we have to figure out, can you come off them? If it's okay to come off them, how long before you have to go back on them? And being on them, I think, no matter what, afterwards, even if you've come off them for the operation, increases the risk of having complications. So it requires a lot of careful vigilance. So this is what we've talked about so far. We've got somebody trying to sort out, are they a candidate? You do the testing, the lumbar drain TAP test, decide they're going to have a candidate for a shunt. You use a shunt, do the operation for the shunt, and then there's what happens afterwards. And that's really what the focus of most of this talk we're supposed to be talking about today. And the post-shunt follow-up, I mean, there's some things that are basically pretty routine that have to be done after A shunt is placed in the brain, just about everybody will get a CAT scan. That's to verify where the catheter is, to look at the size of the ventricles, which sometimes don't change necessarily with normal pressure hydrocephalus treatment. And they don't have to. So that's not really a marker of whether the shunt's working well or not. The marker of whether the shunt's working well or not is, are you getting better? And if you got better with the lumbar drain or the lumbar puncture, you should be getting better with the shunt. What I tell people is that the shunt getting better will usually occur slower than the lumbar drain getting better. But ultimately, it should be getting better. So there's different types of approaches for assessment, taking the stitches out after the operation. Most people will be seen in our clinic about 1 to 2 months after and get a CAT scan to look for some of the issues that we're going to talk about, and regular follow-up. Putting a shunt in to treat NPH is no good unless you're going to follow somebody, because shunts it'd be like buying a car and never taking it into the shop, even when it's starting to make noise and do the wrong things. You need to have a place to go where people can deal with questions you have about, and the question being, is the shunt working or not? So we're going to talk about 2 or 3 things. One thing I haven't put in this talk is a talk about infection prevention. We always watch for infection. Infection with shunts is something that probably occurs somewhere around anywhere between 3 and 6 to 7%. So that's a lot higher than a regular operation where they're not leaving something in your body. You can't sterilize skin, but you can reduce the risk of infection with particular protocols, some of which we've heard about with the Children's Network, the HCRN, where they showed that putting things together in a series of steps that we know have a chance of reducing infection, and carefully following those reduces the risk of infection. And that's what we do to reduce the risk of infection. So infection's not so much a question of, is my shunt working? It's really a question of, is a problem with the shunt? And it usually it has to come out to be treated. You can't treat shunt infections unless you remove the shunt. And then it has to go back in. If it was working, resulting in improvement of symptoms, it can be put back in, but you have to treat that infection. So overdrainage is one of the things of shunt function. Underdrainage is the other. So overdrainage means it's working too well. So we've got problems with overdrainage, and I'll show you pictures of that in a moment, where the brain actually can collapse, and you can get what's called a subdural hematoma, so bleeding on the surface of the brain. As we get older, our brains become stiffer. So if you think of your brain like a sponge, if the sponge is compressed because there's fluid in the middle, and you remove the fluid and the sponge expands, the cavities in the middle of the ventricle shrink. As we get older, our brains become stiffer, so they don't shrink. All you have to do is take enough fluid off that to reduce whatever is going on in the brain that's causing the NPH. And so it has to be enough, but not too much. Because typically what happens if it's too much, the brain will collapse on one side or both, and you'll get these we call subdural hematomas. Headache is a very rare issue in the elderly patient with a shunt, with an idiopathic NPH patient. It occurs in younger patients with shunts more commonly. It just doesn't seem to be a problem with normal pressure hydrocephalus patients who are over 70. This is a subdural accumulation. You can see the CAT scan. It's like a slice taken out of a loaf of bread, and it's the front up here, the right and the left. That's a piece of the shunt catheter, and these are the fluid chambers, which are big. And this one's bigger than this side. So this is fluid right here. There's no evidence of blood in that fluid collection at this time. And this was a situation where we simply were able to adjust the shunt valve up. So it's like the equivalent of dialing a tap so that you turn it down. It lets less out. And this actually re-expanded. The ventricle or fluid chamber on this side re-expanded, and this went away. Sometimes we're not so lucky, and we have to actually go and drain the fluid collection on the outside, while at the same time we're increasing the resistance in the shunt system. So we don't want it to drain as much, in most situations, this just goes away. In some situations, we actually have to physically drain the fluid out or blood out. And these are the programmable valves. This has been the biggest change since I started practice 22 years ago. When I started practice, you put a valve in, you basically picked one setting off the shelf. There were usually only 3, medium, low, or high. You put it in, and that was the end of it. And if things didn't go right, you had to go back to the operating room, take the valve out, put another one in. So this is like big change, big improvement in technology. And so they give you, this is the Codman Akeem. There are others that are here even on demonstration, and this is the Strata. These are 2 of the most common ones used in North America. Each of them has different nuances, different aspects to it. But the bottom line is what they do, and this is an example of the Strata, is in one valve they give you different choices. So in the Strata valve you get 5 choices. In the Codman valve you get 17 choices. But 5 necessarily isn't better than 17. They're just different. So I think as long as the surgeon using this valve is familiar with the issues related to what those pressure settings mean, they can either of them can be very effective in managing hydrocephalus. The beauty is that if you're not draining enough, you can go down in the settings, and that allows more drainage, so less resistance. If you're draining too much, you can go up in the settings. One of the problems with these valves, sort of a nuisance, is that we use tools with magnets in them to reset them, to change the settings. So once you have one of these valves in, every time you go for an MRI scan, we have to have you come in and be checked to make sure that the valve hasn't reset on its own. So you can never assume that the valve is going to stay at the setting if you had an MRI scan. And there should be a process with your physician to make sure that happens all the time. So I think this made a big difference. One of the other things that I didn't mention was the anti-siphon devices. The programmable valves allow us to dial up and down. The anti-siphon device is something that can be added to the shunt so that when you stand up, we don't get sort of a gravitational drainage effect. So if you think of the old siphoning a gas tank where you put a tube in and you lower the tube to try and drain it out, what happens with your shunt is, because of the way these valves are constructed, when you're flat, that's your pressure setting. When you stand up, the pressure difference is between the tip of your shunt and the other end of your shunt. So people drain or siphon. And for some patients, that's actually necessary. I think the lower pressure patients, so-called normal pressure patients, almost need a certain amount of siphoning to make the CSF or spinal fluid flow. So it's trying to find this balance of too much versus enough. So we're going to talk about shunt failure, which is really the biggest thing, the biggest problem I think we face as an issue. And when you pick up the average handbook or a little pamphlet on shunt failure, you get a lot of symptoms like this: vomiting, nausea, headache, irritability, fever, fluid in the belly. And these are really the symptoms that are often associated with pediatric hydrocephalus failure, shunt failure. So this is not typical for patients with NPH. What's typical for NPH is what I mentioned before. The symptoms that went away when you treated the shunt, they come back. And if they come back, then the first thing you've got to ask is this shunt working properly? So return of pre-shunt symptoms. And the 3 symptoms: gait, balance, coordination issues, cognition, memory, and bladder urgency, frequency, and continence. So most patients with NPH, they use the word incontinence as part of the description of the triad, the so-called triad. But just about everybody starts off with urgency and frequency. So when you gotta go, and it happens a lot. And I think what happens is that for many people, if you can't walk very fast, that's where incontinence starts to be the issue. So it's not necessarily a pure type of incontinence initially for most people. And then I think when you come in with these symptoms, this is where people have to step back and they have to actually think. They have to sort of decide, let's sit down and have a talk and look at everything. Is there anything else that could be causing this? Don't exclude, don't say it's not the shunt, but just make sure that there isn't something else that's pretty obvious. So somebody with a bladder infection can suddenly look like their shunt's failing, because as you're 80, 85 years old and you've had NPH, maybe your reserve, what I call your reserve, just isn't that great. So maybe you don't handle stress as well as you would when you're 20 years old or 25 years old. And the effects of a bladder infection, they make people sick. Maybe they make that person bad enough that it looks like their shunt's affected, but it's really the bladder infection. So you got to think about the other things. What else is going on? and work through it. But as I say, for God's sakes, don't ignore the shunt, because if it's there and that's the problem, that can be fixed. So again, coming back to the slide, we look for the other causes. Have they been back on their anticoagulants? Have they been back on their antiplatelet agents? Is there another cause of dementia happening? So some of these things we would only entertain if we verify that the shunt is working really well. So you start off with the basics. We do what we call a history physical exam. Head circumference, that's more of a pediatric thing, but we look in the eyes to make sure there's no evidence of high pressure, which usually doesn't happen. We do an exam to look for problems that suggest there might be something localizing, as the person had a stroke, as the person had something else happen. And we can do a CT scan, MRI scan. Occasionally an ultrasound will be useful for certain things, but not for all. X-ray series of the shunt to see whether it's broken. And there's something that I like to use, not everybody uses this, but it's a nuclear medicine shunt study. And the nuclear medicine shunt study, and I'll show you some examples, gives us an idea of flow through the shunt. So we come in, we check to make sure that the shunt setting is still right, so it hasn't changed. Maybe the person had an MRI, because I've had patients who've had MRIs and just didn't tell anybody. They come in because they can't walk anymore, and you look at their shunt, and it's at the highest setting possible. So you turn the shunt back down, opening down again so that it flows better, and they start walking better again. So it's just making sure that simple things are looked after. Occasionally the shunt has to be tapped to check to make sure there's not an infection. And this is an example of a shunt study. So my pointer's not really that good, but the black ball sort of up in the upper left, they inject the shunt, you get some reflux into the fluid chamber in the brain, and then you see this long streak coming down, and that long streak is the tracer moving through the shunt, and then down at the bottom you see sort of a blob of fluid where this tracer is dumped into the peritoneal cavity. So this is a very useful test. It's not an all or none test, so you can have shunt function is not all or none, but it tells us that it's patent. It tells us that it's open all the way. Maybe if it was flowing slow, maybe the person just needs to have their shunt adjusted. Maybe there's something else going on. However, if you have this kind of study where you see a blob, and it just keeps going on, a little bit of reflux into the ventricle and it doesn't go anywhere, that shunt's blocked. That tells us we should be thinking about trying to fix that shunt. And the good news is that if a shunt's malfunctioned and that's the cause of the problem, it can usually be repaired. The bad news is this happens far too often. So I mentioned that the most common cause of problems with shunts in the elderly and the NPH patients is in the belly cavity, in the peritoneal catheter. And it blocks. And I think we need to do a lot more work on trying to figure out how to make that a better part of the operation. And we're doing some things in Calgary using laparoscopic insertion, trying to find ways to get the catheter into the belly, putting it in a place where it will not block with the stuff that's in the belly. And the things that block it are the fat that's in the omentum, which is the stuff inside that's sort of connected to the bowel, and scars, adhesions. So when people, as we've gone through operations through the years and trauma, we find scars in the belly, and they affect the shunt function. But there are ways to make this better, and we are making it better. So that's the end sort of the talk at this point. I have some, I had some examples on there, but it don't seem to be there. So I'm happy to take some questions, and I can provide some sort of context to some of those tests if you want, if you have any questions that might fit into that. Thank you. So we're going to...
You talk about intermittent failure when patients show symptoms and then for a period of time and then they get better. And I have a son who sometimes he'll show symptoms and for like a week, then he'll get better, and then a few months later he'll show symptoms again. So
the intermittent failure, it's an uncommon thing in the older patient. And when it happens in children, it's usually because they've thought the ventricles were small, and the catheter, the suspicion at least, and this is a lot of it's anecdotal, people have never been able to visualize what happens, but these periods where they wonder whether the catheter tip gets occluded and because they're so close to the walls of the ventricle, and then the ventricle expands a bit because it's not working, and then that allows it to flow again. And potentially the same idea could occur for something in the belly. It is, unfortunately, it's a real tough thing to sort out, because if somebody's sick and they've got shunt malfunction and you know what you have to do, if you're sick and you have shunt malfunction and suddenly you're not sick anymore, that becomes much more of a challenge. So how often do you tolerate that before you decide to do something? And if you're going to do something, can you actually make a difference? So it's a complicated problem. In the NPH patient, you're really not a problem we see from the head, because the ventricles are usually pretty big. But in the belly, it's a problem because of the blockages there.
Hi there, thank you so much for your talk. My mom has adult onset NPH, and she's 76 years old, and recently some of her symptoms have been coming back, and we've been slowly, her neurosurgeon has been slowly increasing the amount of release on the valve, and it's at maximum. So I'm wondering specifically about the increase in bed rest. She's horizontal a lot more often now. Could that have a relationship to the increase in her symptoms? And also, what do you do when the shunt has sort of maxed out at its highest?
So it depends on the type of shunt in terms of how worried I've become for maxed out. I'm more in, the different shunt settings mean different things. But the basic concern I always have is, if somebody's shunt is being dialed down, is it because the shunt is no longer allowing adequate drainage? And occasionally that's the valve, because over time, proteinaceous debris, material debris can gum up some of the mechanisms in the shunt. The most common thing is that the catheter tip in the belly has been slowly choked off, and because the pressure in normal pressure hydrocephalus patients is not normal, but it's not high. It's sort of a misnomer with regards to the name. So being upright for many patients is the only way they will drain adequate amounts of fluid. So it becomes a catch-22 situation. If you're down, you're not going to drain. If you're not going to drain, you have trouble getting up. So you lose that ability to walk. So the first thing I think that I would want to do in that situation is make sure the shunt is actually still patent. Is it working? And if it's not working well enough, then decide to go try and figure out why it's not working well enough.
I tend to produce copious amounts of scar tissue immediately after surgery, to the amount that you'd normally see after 20 years versus the amount that I make in about 2 weeks. So I tend to strangle my catheters. How much do you see in your surgeries where that happens, where you end up having patients who have to have theirs replaced after a short amount of time?
Are you talking the top catheter or the bottom catheter?
Both.
Yeah. Not that often. I think that any catheter in place for a long period of time, especially a peritoneal catheter, will develop a fibrous sheath over it. That's a normal response of the body to it. And sometimes in the belly, the catheter will be floating free, and sometimes you'll actually see a fibrous sheath coating a catheter until you come to where the tip is. Ventricular catheters, unless there's a high protein in the CSF or the spinal fluid, usually don't do that. If the ventricles become too small, they can block just mechanically from that, and so they can get debris or choroid plexus, ependymal cells overgrowing it, something that'll just sort of block the little holes at the end of the catheter. For most people, it's unless there's something mechanical that happens where things in the ventricle collapse down, or in the belly where the catheter ends up in a place where it just gets stuck and can't drain. For most people, that's a relatively long-term process.
Okay, thank you.
My question is, what about that little bulb on top there? My surgeon and my doctor said not to push it. Is that, do you agree with that, or?
So that's the reservoir.
Yeah.
So each valve has, or just about, I would say each valve. Most valves will have a number of different parts to them. The two basic components that are present with most valves are the valve itself, the valve mechanism, which determines when the fluid will flow, and they'll have what's called a reservoir, and that's the bulby part that you feel. So the reservoir has use because it can be tapped with a needle to drain fluid if you have concerns about it. In some valve designs, it can be tapped. You can measure the pressure inside the brain. Depends on where the valve is in relationship to the reservoir. There are some people who will try and use it as a way to figure out whether the shunt is open or not. And that's probably where the most amount of trouble becomes, because it's not very accurate. So when I was training, lots of people used to say, make sure you depress the shunt, and if it refills up, it's good. It means it's open, and if you press it down, it fills up again, then it has to be open. And you can have a valve, depending on the design of the valve, that is totally blocked and can depress and refill, and all you do is you move something back and forth. So there's very little value if somebody's well to be playing with their valve, to be doing anything to their valve. There's minimal value to doing something to the valve, feeling the valve and doing things to the valve if somebody's unwell, if you have a concern about the shunt. It's a test that doesn't give you a lot of confidence or information that's going to be useful.
When you go to the doctor and they put that needle in the window there, they can tell by that, can they not? If it's plugged?
Well, if they try, and it depends on a number of factors. So if the reservoir, so this area they tap, connects to the tube that goes to the fluid chambers in your brain. If your fluid chambers are very tiny, you might not get a lot of fluid off, even if it's open. If the fluid chambers are really big and you put a needle in and you can't get any fluid out, that tells you there may be a problem. But it doesn't tell you much about what's going on downstream. So after the valve, to the catheter that's going to the belly. And that's where it becomes unreliable, I think, for a lot of that. So there are things that we can do that are better and more sensitive to sort out problems with your shunt than simply feeling it. But if you think there's a problem at the top end and you put the needle in and you take fluid, you can't get anything, what happens is that dome sort of umbilicates, it becomes, it gets sucked in and won't refill. That often tells you there's a problem.
Okay.
Diane has two catheters, one that doesn't work and one that works. Both of them have been in, the first one was in about 14 years. That was really good. Second one has been in 12 years, and I expect that sooner or later it's going to fall apart and not work anymore. So, and the first time, or when they put the second one in, they decided to leave the original one in rather than possibly introduce infection. So what do we do the next time?
Very good question. There's a couple of layers to that. One is that nobody knows how long a shunt's going to last, and the longer you go without somebody having to fix your shunt usually implies that's the best scenario you have. The thing that predicts the chance you're going to have a shunt revision or a shunt fix is usually it's just because you've just had one. That's the highest risk period. So 12 years out, you're doing really well, and I mean that's excellent. When you take a shunt, so if you're doing a shunt revision at that stage, you're putting a whole new system in. Old systems people often get worried about because they become scarred, and it's not even so much the risk of infection, it's the risk of trying to pull that out. And if you pull that out and it's attached to something and you get bleeding, that's where I think is the highest risk during a shunt revision. So for an old shunt system, we've sometimes said to just leave it alone. When we do something called an endoscopic third ventriculostomy on younger patients who have had shunt failure and they look like they're a candidate for the third ventriculostomy, I no longer take their old shunts out. Because when we initially thought we had to do that, I found that was actually the biggest problem and nuisance for the people having the operation. So we just do the third tracheostomy and leave them alone, and it's much easier on them. So do you ever have to take it out? The only absolute indication to take out the shunt is if there's an infection. So when you have a shunt malfunction, there's two different sort of approaches that people tend to take. One is, if it's broke, fix the entire thing. And the other is, if it's broke, I mean, if there's something wrong with it, find out what's wrong with it and then just fix that. So that's what most neurosurgeons do. You don't replace the entire thing, because then I think that increases the risk of infection and that increases the risk of complications. So if it ever malfunctions again, try and find out what part of it's not working and see if that can be fixed. I have seen people who've had up to 4 shunts put in with only one working, and each time it failed in places, they just put a new system in. You can get away with that. I don't think that's necessarily a great approach, and if you have an infection, I mean, eventually you have an infection, then it means you have to take everything all out, and then that's a lot to go through all at once. That's pretty good. It's 26 years. That's good. It's very good.
When you get an infection, can you usually take care of that?
Yes. So I tell people that infections are rarely life-threatening, but they are the biggest pain you could ever imagine. Because the only way you can deal with an infection with a shunt is you have to take the entire thing out. And that means for a patient who has NPH, and let's go back a bit. So you take the shunt out to treat it. Some people, when you take the shunt out, they're so dependent on the shunt to keep their intracranial pressure low that they require a backup. So they need a tube coming out, a drain, and to tie them over while you treat the infection. For people with chronic hydrocephalus, sort of NPH, you can take the shunt out and often not put them through the hassle and the risk of having a drain in. But what happens is that their symptoms, their NPH symptoms, come back during that time. And so usually you have to usually start treating with antibiotics. You take the whole shunt out. You treat with antibiotics for usually anywhere between 10 and 14 days. And then we put the shunt back in. We have a protocol that is for so the infection risk for a first-time operation is, I said, somewhere between 3 and 6%. In our center, it's 3.5%. But for a repeat infection, somebody who's had an infection, you're doing a reinsertion, it probably is double what the baseline rate is. So we go through a different sort of process to try and reduce that risk of infection. So the answer is yes, it's treatable. Rarely is it life-threatening, but it does require a lot to get it over with. Anybody else? Well, again, thank you very much. It's nice to have a very attentive audience, for even as we're getting close to the end and everybody's stamina must be challenged. So that's good. So thank you for coming. And if you have any questions afterwards, I'd be happy to talk to you. Thank you.